ஸ்டார்ட் பண்ணலாமா சார்? சூர்யா
ஸ்டார்ட் பண்ணலாம்.
அப்போ நான் ஃபோன் கட் பண்ணிடுவா.
ஓகே சார்.
ஆல் ஓகே தானே? எல்லாம் அன்மியூட்ல தான் இருக்கு.
எல்லாம் கரெக்டா இருக்கு.
சரி, ஓகே. So, good morning. Today's class is about facial trauma and CSF rhinorrhea. So, face is quite a complicated structure with a lot of bones with relationship between each other. So, if there is a trauma that occurs in the face, the trauma is always unpredictable, and which bone will get involved and what are the clinical features is always different from one person to another. So let's immediately jump into the topic facial trauma and CSF rhinorrhea. So first, I'll put up on a question. The question is, while playing cricket, an young boy was hit on the nose. On examination, the nasal septum was not deviated. The following about the patient is true. I read out the options. He should be taken up for open reduction 1 week later. He should be taken for closed reduction as soon as overlaying edema subsides. Septoplasty should be done in the same sitting. He is having gingival fracture. As the question goes, they didn't mention the diagnosis. They have just told you nasal septum was not deviated. So if nasal septum was not deviated, it means that some other problem would have been there because he was hit heavily on the nose, but still nasal septum is not deviated. For this, we have to know basic anatomy of external nose contour. So let's dive into anatomy of nasal contour. So looking at the anatomy of nasal contour, just look into this. This is our nasal bone. There are two nasal bones. So it is in orientation superiorly with frontal bone, inferiorly with this upper lateral cartilage. So why nasal bone fracture is important? Because the most common facial bone to get fractured is nasal bone. So this nasal bone has attachment with frontal bone as well as this upper lateral cartilage found below. So if a trauma to the nasal bone occurs, a lot of conditions can occur. First, the trauma can be of any direction, from the side, from below, or from above. So point number 1 is we should note whether the fracture is isolated or associated with other fractures. How can we look upon it? So nearby a lot of bones are there, so we should look upon the clinical features of that corresponding bones, but the one that should be immediately looked upon is nasal septum. So we should look for whether nasal septum is deviated or not. So if the nasal septum is deviated, it can be of two types: Chevrolet fracture and Gingival fracture. So how can you differentiate nasal septum fracture into two types: Chevrolet fracture, Gingival fracture? So if this is the lateral wall of the nose, if the blow is from the front, we call it as Gingival fracture. If the blow is from below, we call it as Chevrolet fracture. Okay, so what the blow from front can cause? it can cause an horizontal fracture line. From below, what it can cause? A vertical fracture line. So point number 1, Chevrolet fracture, the blow is from below. Point number 2, it causes vertical fracture segment. So George wave fracture can cause horizontal fracture segment. So first we studied about nasal bone. If nasal bone is fractured, we should also look upon nasal septum. We can classify nasal septum into two: Chevrolet fracture, George wave fracture. Straight away. So if it is from straight, George away, straight, George away. So you can answer straight away that George away is the blow from the straight. Okay, from below it is Chevrolet fracture. Clear? So what are the clinical features specific for nasal bone fracture? First clinical features that we can look upon is, first there will be complaints of nasal obstruction. Then there could be a deformity of external nose. So it is more of aesthetic significance than of functional significance. So the patient may think that he is not good looking, the nose is not straight like before. So this symptom is main of aesthetic significance to the patient, but you should watch for nasal obstruction. So okay, so based on the displacement of the fracture segment, we can call it as displaced fracture nasal bone or undisplaced fracture nasal bone. Clear? So let's look upon this CT facial bone. With axial cuts. Here, this is the area we should look for nasal bone fracture. Just look into this. Here, it is maintaining the same plane, but here it is maintaining the same plane, but here it is not maintaining the same plane. It is displaced. So it is displaced. So if it is displaced, step number 1, if it is displaced, we should ask for the symptom of the patient. So the patient, whether he is having any nasal obstruction, then whether he is having any deformity of nasal nose. So if there is a deformity, we can plan for surgery from the consent of the patient. So the surgical management can be different based on the presentation. So a patient fall down, he immediately comes to the casualty. The duty ENTPG goes there, examine the patient, he finds nasal bone fracture. So if it is very gross deformity, the patient feels that he should be corrected with that deformity, and there is no other problem in the entire body. Orthopedics should be normal, neurosurgery should be normal, no other problem, only isolated nasal bone fracture is present, that is giving a bigger deformity for the patient. So what you will do, you should go for immediate reduction. Immediate reduction of fracture segment. Okay, the patient fell down. He doesn't notice on the first day. He comes to the OPD on the second day. He is telling that my nose is not looking normal. I want my nose to get corrected. So he says that you don't waste the time. You operate upon me today itself. But the ENT surgeon says, no, I can't operate upon you because if it was yesterday, I could have operated. But today, I can't operate because after 24 hours, there will be edema, which will take at least 5 to 7 days to settle. So which means 1 week. So if the patient didn't turn out on day 1, you should wait for 1 week. You should canvas the patient that you should wait for 1 week. You can do the surgery on second week. Third week. So second week to third week, you can do the surgery. Once third week crosses, you should not do the surgery. See the timeline? The timeline 1 is you can do immediately. Timeline 2 is more than 24 hours. Initial 1 week, you should not do. Then 2 weeks to 3 weeks, that is 8 days to 21 days. You roughly have it as 8 days to 21 days. You can do the surgery. If the patient crosses more than 21 days, you can't do the surgery again because the fracture segment would have formed fibrosis. This fibrosis, so if we do surgery, we are going to disturb the fibrosis natural healing mechanism. So technically, we are not keeping any plate. We are just doing closed reduction most commonly. So if we are going to disturb the natural fibrosis, it's going to cost the patient a lot. So you should not do the surgery again more than 3 weeks. This is the timeline for surgical management of fracture nasal bone. So we have seen about fracture nasal bone. We have seen about fracture extending into the nasal septum. Now, what is the treatment? So the patient is okay. He doesn't seem to have deformity. Conservative management is enough. So what surgery we are going to discuss? We can do closed reduction and then open reduction. So we can do closed reduction as well as open reduction. So how a closed reduction can be done? Just look into this. So there are 2 instruments. One instrument like a beak of a bird. Next instrument having a straight architecture. So this instrument name is called Walsham forceps. This instrument name is called Ash forceps. Okay, so you can use this instrument to reduce the nasal bone fracture. So I'll show you a video how a Walsham forceps is being used. Walsham forceps is being used to reduce the nasal bone fracture. See here, this Walsham forceps is inserted into the nasal cavity. One limb externally, one limb internally. See here. So this way, the fracture segment is first out fractured, then it is brought back to the original anatomical position. So this is how Walsham forceps is used for both the sides. This can be done in general anesthesia as well as local anesthesia like this. So this is how a Walsham forceps is used. So Walsham forceps, they can ask in picture-based instrument question. So Walsham's forceps, the beak-like appearance you can use for close reduction of nasal bone fracture. So this Ash forceps you can use for septum. If nasal septum is deviated, you can, this traumatic septal deviation, you can use Ash forceps. So this is how the closed reduction works. Then if the fracture is associated with a external injury, then you can go for open reduction. Open reduction, you can straight away visualize the fracture segment and can reduce it. Then apply nasal splint. Then you can apply nasal splint over the reduced fracture segment. So closed reduction is most commonly done. So it can be done in local anesthesia also. Open reduction is done for open injuries or the fracture segments which can't be reduced by closed reduction. So these are the two indications for open reduction of nasal bone. So that ends the fracture nasal bone. Most common fracture, it can be associated with septal fractures also. It is two types, chevalet, charge away, straight away. So front, charge away, below chevalet fracture. So this is how the nasal bone fracture points pan out. So now we can enter into the next thing, Leaford fracture. So what Leaford fracture means? So Leaford fracture is nothing but, Leaford described the pattern and complex fracture lines involved in the face. So the fracture line following a road traffic accident can be of three types. One is type 1, inferior to nasal cavity. So here, root of nasal cavity inferior to orbital floor. So roof of nasal cavity and inferior to orbital floor. So it will be a triangular shaped fracture pattern. Here, this is completely involving almost all the bones of the skull base. So this is craniofacial disjunction. So type 3 Leaford fracture is craniofacial disjunction. So type 1 is, it's a mild severity. The fracture line runs below the nasal cavity. So type 2, above the nasal cavity, that is root of the nose, inferior to the orbital floor. Type 3 is complete separation of the skull base bones. It can involve all the bones. It can involve maxilla, it can involve nasal bone, it can involve frontal bone, it can involve zygomatic bone, it can involve even the inside bones like sphenoid. So these are all the bones can be involved in Leaford type 3. So if they ask what are the bones involved in Leaford 3, the extra bones are sphenoid, zygomatic. So Leaford 1 is maxilla. Leaford 2 is maxilla with zygoma with nasal bone. So here also, okay. So see here, maxilla. Here maxilla with zygoma with nasal bone. Here also maxilla, nasal bone, orbit, all are involved completely. Apart from these regular structures, sphenoid and zygomatic is also involved in Leaford type 3. Okay. So involvement of zygoma complex is seen in A, Leaford 1, B, Leaford 2, C, Leaford 3, D, Leaford 2 and 3. So it is Leaford 2 and 3 because in Leaford 2 and 3, we have involvement of zygoma. Okay. So as we have completed the leaf-foot fracture, we can also complete the question which we started with. So the boy is having a nasal bone fracture. Septum is not deviated, which means that it is an isolated nasal bone fracture. You should treat the nasal bone fracture either immediately or between the second and third weeks. You should not do at week 1. You should not do at week 3. So here what happens? He should be taken up for open reduction 1 week later. See, open reduction you can't do straight away. Closed reduction as edema subsides. Septoplasty should be done in same sitting. See, again I am telling here septum is not involved, so septoplasty should not be done. It is not a septal fracture, so Jargeve fracture we can't describe. Clear? So Jargeve and Chevalet is only for septal fractures. Okay. Then we are looking upon only 2 options regarding nasal bone fracture. So this boy can be taken immediately. That option is not given here, or else he can go for closed reduction as soon as the overlying edema subsides. So we have completed nasal bone fracture. We have completed the question which we started with. Now we have completed the leaf-foot fracture also. Then we can jump into another question for the day. So a 50-year-old male following an RTA presented to the casualty with multiple abrasions all over the face, and there is a periorbital contusion of right eyes, and CT penis revealed the following picture. Okay, so the person is having periorbital contusion. So the CT penis is having this particular picture. The patient is following a road traffic accident. So can you name this sign? Anyone? Are you familiar with? Yes, perfect answer. So this is teardrop sign. So this is teardrop sign seen in, what is the diagnosis? Anyone? So teardrop sign is seen in, what is this one is called? So floor of the orbit fracture. So floor of orbit fracture, teardrop sign is always been asked as an one-liner. Most of our otherwise called it's a blowout fracture. So that's the thing that you need to know, and you should be familiar with the CT-PNS finding also. See, the options are leaf-foot fracture 1, leaf-foot fracture 2, blowout fracture, Chevalet fracture. Leaf-foot 1 and 2 should involve the maxilla. Chevalet fracture should involve the septum. So blowout fracture, otherwise called fracture floor of the orbit, is the answer for this question. Clear? So we have done with floor of the orbit fracture also. Now we can go for the next important topic for the day. I'll start with the question. So all of the following statements about CSF leak are true except the commonest site of CSF leak is lateral lamella of cribriform plate. Beta 2 transferrin estimation is highly specific for diagnosis. Fluorescent dye can be used intrathecally for diagnosis of site of leak. MRI T1 images are best for diagnosis of site of active leak. So the entire description about CSF leak is given over here. First, we should know the site of CSF leak. Then we should know the investigation point of the CSF leak. Then we should know about the dye which is used pre-operatively and we use during operation. Then whether MRI is indicated or not. So all points are in our chamber. So whether which of the answer we can discuss once we go through the CSF Rhinorrhoea chapter. So I'll start with CSF Rhinorrhoea. So some of you are answering, so I'll tell the answer at the end. So we'll start with CSF Rhinorrhoea. So CSF Rhinorrhoea is nothing but there is leakage of CSF fluid through a defect. Just look into this defect in the bone. Is this enough? So only defect in the bone is not enough. There should be a defect in dura mater also. So then only the subarachnoid space will give away CSF fluid. So there should be a defect in the bone and there should be a defect in the dura. So technically here there will be nasal cavity. Here there will be cranium. So CSF fluid from the cranium enters into the nasal cavity. So how it is going to happen? So as we all know, what could be the most common cause? The first one is trauma. So does trauma alone cause CSF leak? It's not like that. There are a lot of non-traumatic causes. First, the familiar things. What are the familiar things? Yeah. So Prakali has answered iatrogenic. Yes, iatrogenic is a fantastic answer. So iatrogenic CSF leak is very important. Why? Because this iatrogenic has no proven causes. Some says that obesity can be a cause that leads to iatrogenic spontaneous CSF leak. That leads to iatrogenic spontaneous CSF leak. Okay. Now, what are the other causes? It can be due to tumor or pseudotumor. What is pseudotumor? What is pseudotumor? It is pseudotumor cerebri. Okay. So the thing you would be learning in physiology and all. So there could be a brain tumor that is causing pressure, or there could be only raised intracranial pressure that is causing pressure over the meninges and it is causing leakage. So it could be a tumor, it could be pseudotumor cerebri, but the important thing is traumatic and spontaneous. So these are the most important causes, and the most common cause is traumatic cause. Now we are familiar with how it will occur. Now we have to go through where it will occur. So where the CSF leak or CSF rhinorrhea is most commonly documented. Anyone? So where the CSF leak, CSF rhinorrhea is most common? So cribriform plate, that was a fantastic answer. So I'll tell you clearly. So I'll give you a small question. The only sinus that will not have CSF rhinorrhea is the only paranasal sinus that will not have CSF leak is anyone? So there are four paranasal sinuses. There are four paranasal sinuses: maxillary, frontal, sphenoid, ethmoid. So there are four paranasal sinuses. The only sinus that will never have CSF rhinorrhea. So the answer is maxillary sinus. So maxillary sinus has nothing to do with the cranium. So just look into this. We'll detailedly look upon the relation of every so one has asked iatrogenic and idiopathic. Okay. So in iatrogenic, it is due to operative causes. Okay. In spontaneous, it is due to obesity. Okay. So in iatrogenic, it can occur follow any nasal surgeries like FIS. When we are operating upon frontal sinus or sphenoid sinus, we can inadvertently injure the skull base and can cause injury. That is iatrogenic. Our spontaneous CSF leak is due to a spontaneous leak without any cause. Okay, so that is idiopathic. Okay, so is it clear? Shall I proceed? So are you clear with idiopathic and iatrogenic? Okay, thank you. So just look into this bone. You should be very familiar with the anatomy of all the paranasal sinus bones. First, we are seeing the frontal sinus. Then we'll be having the sphenoid sinus over here. Then we'll be having ethmoid sinus over here. I'll come again. See the topmost frontal sinus, that is the forehead. Then the ethmoid sinus is in the middle. Then the sphenoid sinus is the posterior most. Now tell this frontal sinus posteriorly it is related to the cranium. Okay. This ethmoid sinus roof is related to the cranium. This sphenoid sinus roof as well as posterior wall is involved with the relationship of cranium. I'll come again. See, have close attention. Frontal sinus superiorly, inferiorly it is safe. Posteriorly it is in connection with anterior cranial fossa. Okay. Ethmoid sinus again it is in connection with anterior cranial fossa. This sphenoid sinus roof is in connection with middle cranial fossa. Sometimes posterior wall, which is adjacent to the occipital bone, sometimes can even cause leakage due to posterior cranial fossa tumors. So it is not that the posterior cranial fossa is far behind, it will not cause CSF rhinorrhea. It can cause CSF rhinorrhea if there is a cleval chordoma. So if there is some tumors of the occipital bone can compress the sphenoid bone from behind, can cause CSF rhinorrhea also. But the thing that we should pay attention is our ethmoid sinus is the first attention that we should give. Frontal sinus is very easy. The posterior end of the frontal sinus is related to the anterior cranial fossa. So if there is some frontal tumors or if we are injuring the posterior table of the frontal bone, then only it will get CSF rhinorrhea. But in ethmoid sinus, it is almost always a possibility for CSF rhinorrhea leaks following a surgery. See, you just look into this bone only, how thin the bone is. So this thinner bone, so these are thinner bones. These thinner bones that forms the roof of the ethmoid sinus is called cribriform plate of ethmoid. This cribriform plate will be like a thin sieve-like material. So it can easily get injured with a small strike of the instrument. If I am doing a surgery, I should do very carefully. If not, I may injure the cribriform plate of ethmoid. And also, we were studying about nasal bone fracture. If the impact from the nasal bone fracture can even pass to the ethmoid as cells, and it can directly injure the cribriform plate of ethmoid. So cribriform plate of ethmoid is commonly injured part in CSF rhinorrhea. Okay. So for spontaneous also, it is a thin bone. If there is a raised ICT due to a tumor or a pseudotumor cerebri or any spontaneous cause, idiopathic cause without any cause, only obesity will be the cause. It can cause this CSF rhinorrhea through this cribriform plate of ethmoid. So we have understood about how a CSF rhinorrhea can come through the skull base. So frontal sinus, ethmoid sinus, and sphenoid sinus. Now we can look here very clearly. See, this is our frontal sinus. posterior related. This is our ethmoid sinus, roof related. You may ask, ethmoid sinus is related posteriorly? No. The posterior end of the ethmoid leads into sphenoid sinus. In fact, you can't do a sphenoidotomy without removing the ethmoid hair cells. If you remove the ethmoid hair cells in face only, you can go into the sphenoid sinus. So the sphenoid sinus alone is related superiorly and posteriorly with the cranium. Superiorly with middle cranial fossa, posteriorly with posterior cranial fossa. Clear? So the site of leak we have studied. Okay. So what is the clinical feature of CSF rhinorrhea? So how can you differentiate? So this is cold season. We may all get some rhinitis and stuffiness of the nose. So how can I differentiate from a normal nasal discharge due to infection and CSF discharge? First thing is the normal nasal discharge. Yes, that was a perfect answer, Sindhuja. So nasal discharge, first of all, it will be mucoid in consistency. This CSF is clear watery fluid or serous. Okay, so it's a clear fluid. So it is mucoid. It is clear watery fluid. So what it will cause? So in school times, we used to have a handkerchief when we are having a viral rhinitis. So repeatedly we'll cough. Okay. So once we brush away the secretions from the nose, it will become very, very hard. That handkerchief will become very hard or stiffened, hard or it get stiffened. So a nasal discharge can cause the handkerchief to stiffen up. But here we are having only watery discharge. It will not cause stiffening of the handkerchief. This is called handkerchief test. So this is a bedside test we can do. This handkerchief will be stiffened in nasal rhinitis. It will not be stiffened in CSF rhinorrhea. Then what else? So it is Saturday night. Someone did a party. He fell down. He came to the casualty with the complaints of epistaxis. NEET-PG went and see the patient. The patient repeatedly using handkerchief to brush away the secretions. First thing I noted is it is not stiffened. Second thing I noted is, so it is the handkerchief, which is very white in color, turned out to be having two spots. One spot suggestive of blood. So because as it is a traumatic CSF rhinorrhea, it will have blood clot in the center surrounded by a halo of CSF. This is called halo sign. Halo sign seen in CSF rhinorrhea. Okay. So like this is the red blood clot. This is the outside halo due to CSF fluid. Okay. So this is the second sign, bedside sign we can see. So what else we can see? Does anyone know what reservoir sign is? So this patient, there will be a small leak. So if the small leak, sometimes we can miss it. But if we make the patient to lie in supine position for 5 minutes, then we ask the patient to bend forward like this, there will be nasal discharge of serous watery fluid of CSF rhinorrhea like this. So this is called reservoir sign or teapot sign. So why it is called reservoir? Because normally the small drops we may miss it. Okay, but if we ask the patient to lie in supine position, if we take 5 minutes for the CSF to collect inside the nasal cavity, once the patient bend forwards, all the collected nasal discharge will come out in the form of clear watery fluid. This is reservoir sign. Clear? Now as you saw this lady, no, you can collect that CSF fluid, you can send the CSF fluid for analysis. Okay, so what are the two major things? The first thing is the glucose estimation of the CSF fluid will be 2/3 of the blood sugar. So it can be around 45 to 85 milligram per deciliter. So it is 2/3 of the normal blood sugar. So it will be around 45 to 85. Then we can do beta 2 transferrin estimation. We can do beta 2 transferrin estimation. This is very important investigation. If the collected CSF fluid contains beta 2 transferrin, it is only for CSF fluid the beta 2 transferrin will be present. But in nasal discharge, this beta 2 transferrin will be absent. Few surgeons nowadays also use beta trace protein. So this is also used, but it is quite costly in our setting. But what is the advantage is it is quite more sensitive than the beta 2 transferrin test. So the sensitivity of beta trace protein is higher than the beta 2 transferrin test. Clear? So we have seen about how a CSF leak could occur in the bones of the paranasal sinuses. Then we have seen the important clinical features. Now we have taken that sample, we have sent for biochemical analysis. We got some results, that is sugar, beta 2 transferrin, beta trace protein. Okay. Now we have to exactly locate the site of the defect with imaging studies. Okay. How we can locate the site with imaging study? First, we can do a contrast, high resolution contrast CT-PNS. So this contrast may spill inside the crevices and can show up the larger defects. It can show only larger defects. Small defects it can't see. Okay. For small defects, the diagnostic test of choice is CT cysternogram. Clear? Okay. So what is the procedure for CT cysternogram? We need a ENT doctor. We need an anesthetist. We need a pathologist. All three should act together for this test. We should go to the CT room. That anesthetist should give lumbar puncture. Through the lumbar puncture only, contrast is injected. Okay. See, dye is not injected. Contrast is injected. So through lumbar puncture, contrast is injected with the help of anesthetist. Now I take over the case to the radiologist. This radiologist should do serial CT scans. Okay, serial CT scans in head up, head down position. Why? Because I just tell you how. So if this is the table, if the patient is lying like this, if we are injecting the lumbar puncture needle, the contrast, it will not go through the cysternal spaces in the near to the skull base. So we should tilt the couch with leg facing upwards, head facing downwards. So the contrast will proceed to the head. It will get spread into the cysternal spaces. That's why it is called cystonogram. Get spread into the cysternal spaces. So these are minute spaces present at the skull base. So these cysternal spaces, if the cysternal spaces receive the contrast, it can identify the defect. So this defect will be identified very clearly. Again, its most common site is cribriform plate of ethmoid. But if it is a trauma, it need not be cribriform plate always. Sometimes it can also be other areas also. So we should locate the site of injury. Okay, now we have located the site of injury. Now we can do two things. One is use an endoscope, visualize the defect. You can use a CSF rhinorrhea leak repair. Or if the leak is very smaller, that is even suspicious in this CT cystonogram, it is not confirmatory, it is only suspicious, 2 millimeter, 3 millimeter defects are there, means you should use an intrathecal fluorescent dye mixed with CSF, inject back to the patient. Now this is done just before the surgery. This is done just before the surgery. Clear? So this procedure, you plan it, you do it, then you proceed the patient to the operating theater. Now the operating surgeon should identify the defect. So for identify the defect, we can remove any structure in the nose. It can be ethmoid sinus, it can be middle turbinate. So we can sacrifice any structure to visualize the defect. Okay, this defect is very important. So we should visualize the defect. Okay, so once we visualize the defect, what we can see is, see here, this is a typical case that we did. So this is the area of leakage. Just see, this is our leak site present at the cribriform plate. This is posterior ethmoid. So see how rapidly the leak is coming. I'll show again. So you just have orientation of this endoscopic picture. So here the leak site is identified at the roof of the posterior ethmoid. So this is a bigger leak. It is almost 7 millimeter leak. So leak site is identified. First, we can do, this is actually a 7-layer technique. We are using 7 layer. So first one is fat is inserted as a first layer. This is fascia lata as second layer. Just look into the fascia lata. It is harvested from the thighs. Then see, we should tuck the fascia lata into the defect. If this is the defect, we should tuck the fascia lata into the defect. After that, third layer is surgicel. So surgicel is a synthetic foam-like material that will adhere the defect. So fourth layer, again we are keeping some bit of fat. This fat can be taken from the abdomen or from the thighs, from which we are harvesting the fascia lata. Fifth layer is again a surgicel layer. Then finally, sixth layer, we are keeping a gel foam. Gel foam is commonly used a synthetic material. It will stop the bleeding. It will again form a layer. Seventh layer, this middle turbinate is rotated superiorly to fill the defect. This is how final packing is done. So it is all done under endoscopic field. So this is how a CSF rhinorrhea leak repair is being done. Okay, so it's simple thing. It's like there is a small hole or puncture in our cycle tire or car tire. We are looking at the puncture with the use of some water or some air. Once we identify the puncture site, what we are doing, we are applying some adhesive and pasting it over the surface. See, this tire is a surface full of friction. So if we stick an adhesive, it can easily stick over the defect. But this CSF, this nasal mucosa, these are not the surface with friction. So if we stick over it, it will not be inside it for longer time. So we have to tuck inside the defect. We have to tuck inside the defect. We should make a lot of layers before the dura comes in contact with the bone. So using this method, we can close the CSF rhinorrhea repair. So you may ask, sir, if you find a CSF rhinorrhea repair, can we try conservative management? See, only 3 hours of spinal anesthesia, okay, it is having some bit of CSF leak, but the patient is having post-dural puncture headache to the severe extent. Okay, so what if small CSF is keep on leaking, means it can cause severe headache, it can lead to meningitis. So whatever smaller defect it may be, we should definitely operate upon the case. Conservative management is not indicated in CSF rhinorrhea. So whatever CSF leak it may be, it can be a traumatic, it can be a non-traumatic, it can be spontaneous, it can be iatrogenic. You should immediately do CSF leak repair. So how you will do? First, you can take a CT cystonogram. First, you can do a biochemical test. You can do a CT cystonogram. Then you can plan for surgery. Now, you can enter into this question. Head injury, patient is conscious, CT showing fracture and CSF leak through right nose. What is the next line of management? So this is like a typical NEET question. See, the options are very harmless. Head low position, wait for spontaneous leak to stop on its own. Very diplomatic option. Immediate cystoscopy and transcranial surgery to close the defect. So it is very violent option. So endoscopically stop leakage. So immediately you should not plan surgery. You should do an investigation on first hand, because the surgeon is not a magician. He should have idea about where the leak comes from. Okay, so the difference between option D and option C is, you should do a CT sonogram, you should have an idea about the site of defect, then only you go for surgery. So the answer for this question is C. Clear? So I have completed CSF rhinorrhea, how it is, etiology part, clinical presentation part, and finally the treatment and the videos which I showed you. Now we can rush through a few questions which we discussed. Mechanism of chevrolet fracture of nasal septum is? Anyone? So the answer is D, blow from below. Charge away, blow from front. Okay. A 60-year-old man fell down from height and he sustained an abrasion over the root of the nose, and he could see an external deformity of his nose. He came running to the ER, and the duty ENT surgeon examined and advised for CT facial bone. Then planned for surgery. Ideal time for correction of fracture nasal bone. So why I put upon this question is, see, the essence of the entire question is at the last line itself. So if it is a lengthy question, you should immediately go for the last line. If you are not thorough, if the last line is not enough for the diagnosis, then you can read the entire question. See, this reading this much time is waste for you, right? So the answer is, as all the people told, it is immediately you should operate upon this patient either in general anesthesia or local anesthesia, provided that he should not have any other compromise. Okay. So the answer is A. Okay, clear. So 18 responses, all of them are correct. Okay. Okay. So we'll go for the next question. A patient present with enophthalmus after trauma to face by blunt object. Diagnosis is. So the options are fracture floor of the orbit, fracture lateral wall of nose, fracture roof of nose, Leafwood's fracture. So fracture lateral wall of nose, there is hardly any bony structure. So if at all, it could be nasal bone fracture. So other options are not that much correct. So the answer we can straight away go for fracture floor of the orbit. Okay. So everyone answered correctly. Superb. So we can go to the next question. A young male brought to the hospital after accident. Patient is stable. Patient is stable, but clear water-like fluid is coming from the nose. See, the usage of words is very ironic. Okay. So the patient is stable. You may think that the patient is stable. Okay. Okay. You may think that patient is stable. We can go for conservative surgery. We can do a nasal packing. The CSF leak can settle down on its own, and we can go for repair afterwards. So whatsoever, you should do an immediate repair wherever the situation may be. If you can't operate, you better refer to the higher center, but the patient should be operated. So you're telling about the traumatic CSF leaks which we are seeing in the daily ER setup. If a spontaneous leak is there, what will you do? So the patient would have seen the spontaneous leak only later. Okay, so most of them has answered immediate repair. So please, MRI has no role, conservative has no role. Only immediate repair is the need of the hour in CSF rhinorrhea repair. So the thing which I am telling to you people is, if there is a spontaneous leak repair, the patient will present to you quite later only, because first he'll convince himself that this is not a problem. Then he will start getting severe headache episodes. After getting severe headache episodes only, what he will do now, he will straight away come to the ENT doctor. In that patient, you should do you should do the CSF leak repair as early as possible, but not on the day itself, because he is an obese patient. He may have any this obesity syndromes may be present. He may have heart condition. So you should evaluate all such conditions. Then you should plan the surgery 2 or 3 days later. So spontaneous CSF repair, technically you can't do the surgery immediately, but if the option is immediately, you should put upon immediately only. But technically, as the patient presents quite later only, we can evaluate the patient for all the complications, because obesity can be associated with all such complications. So you should do all the investigation, then you should proceed for surgery in spontaneous CSF leak. So we have seen about facial trauma, how the bones are getting fractured, CSF leak. I'll give you a bonus question from recent NEET exam. The latest NEET exam question is this. See, intracranial complication in COVID is due to spread through which of the following? They have given this question, they have given this photo, they have given this star, everything they have given in the recent NEET. Clear? I think this is recent NEET or recent INI-CET. So last 2 papers, this question has been asked. Okay. So the answer is cribriform plate of ethmoid. Perfect. See, one has answered jugular foramen. Jugular foramen is not present in our nose area itself. It is present somewhere around the temporal bone junction. So the answer is cribriform plate. See the sieve-like appearance of the cribriform plate of ethmoid. So it is very papery thin. So why the sieve-like appearance is there? Anyone? What the sieve-like thing will do? Any use of this sieve-like appearance of this cribriform plate of ethmoid? Olfactory nerve will pass through. Yes. So for passing the olfactory nerve, this bone is designed in such a way, but that makes it a strong contender for easy damage due to everything. It can be damaged due to spontaneous, it can be damaged due to trauma, it can be damaged due to even COVID. This COVID rhino-orbital mucormycosis. So if it comes in the nasal cavity, so most commonly it will affect the ethmoid sinus, this rhino-orbital mucor. So this will go above, breach our cribriform plate. It can cause intracranial, that is cranial mucormycosis. Okay, cerebral mucormycosis. Sometimes it can also go to the orbit. Through the orbit, they can enter into the cranium also. So most of the times it passes through the cribriform plate of ethmoid, but sometimes after it is breaching the orbit, it can also go to the cranium. So this orientation of the paranasal sinuses with the skull base is very important, because not only this, they may ask this in complication of sinusitis, they may ask this in complication of fist surgery. So if you are reading rhinology, this is a go-to chapter. You should have thorough understanding. So that ends my session. Anyone having doubt can kindly ask. Thank you, Swati. Thank you. Okay, one has show forceps images. Yeah, I'll show it. Wait. As she has asked, I'll show the forceps. See, this is Walsham's forceps. Okay. So this is Walsham's forceps. Okay. This is beak-like appearance we can insert into the nose. One limb externally, one limb into the nose. Okay, so we should do 2 times. If nasal bone is fractured, both the nasal bone should be reduced. Okay, if you reduce one nasal bone is not enough, because these nasal bones are in connection with each other. So a patient having only one side nasal bone fracture, you can't do that. Okay, so CSF Rhinorrhoea, first question. Yeah, I'll show it. So is this question, or this is nasal bone fracture question? Yeah, okay. Yeah, sorry, I'll explain this. This one. So all of the following statements about CSF are true except. So we have seen lateral lamella of cryptosome plate, correct answer. Sorry, this is correct option. Beta 2 transformation, correct option. Fluorescein dye can be used intrathecally for diagnosis of CSF leak. Again, correct option. This MRI is not so needed for identifying CSF leak. Okay, thanks. Someone has told that I didn't revise this question. Yes, so the answer for this question is D. Okay, I hope you have understood. So anyone having any doubt? So a gentle advice. So if you people are studying this topic today, so while studying this, you can also study a little bit of anatomy part also. Okay, what anatomy part you can read? You can read this other open and closed reduction can be done immediately. This closed reduction can be done even on patient couch itself. If we are such trained, we can, without anesthesia itself, we can do the closed reduction immediately. I am talking about nasal bone closed reduction. We can do immediately. This open reduction and all we can't do immediately. This is a cumbersome procedure. We should plan adequately. We should rule out the fact, because this open reduction can cause an external scar. So we can't do an open procedure just like that. So it is not done immediately. You should plan. You should rule out the fact that close reduction is not the treatment for nasal bone fracture. Then only you can proceed for. Open reduction. Okay, open reduction is an external surgery. Okay. Any other question? Okay. So spontaneous CSF leak, shouldn't we do conservative management for 70 days before endonasal endoscopic repair? Yeah. So this conservative management part, again, it is not for trial and error method. It is just for evaluation of the patient. I'll tell you. See, your Suji Xavier is talking about conservative management for CSF rhinorrhea for initial 7 to 10 days period. Okay, I'll tell you how. See, if the patient has been operated for CSF rhinorrhea repair, what are the other things that we should give? We should reduce the intracranial pressure with the help of acetazolamide. Okay, then we should use stool softness like Dulcolex. Then we should use diuretics. So all the pressure sensations should be relieved. Urine for diuretics, stool softness, for pressure acetazolamide. So these 3 should be started immediately when you suspect CSF leak. So this thing you should continue even after CSF leak repair. So what I am telling is, so the suspicious site has been probed. So we are thinking that this patient is having CSF rhinorrhea. So immediately we should reduce all the possible pressures in his or her body using acetazolamide, Dulcolex, diuretics. So we should do this. So as Suji Xavier asked, 7 to 10 days. So if the patient has admitted today, I have found out or suspected CSF rhinorrhea today itself, I will do a CSF analysis and a CT stenogram tomorrow. See, biochemical report, I will not wait and all. If I have a leak site in CT stenogram, I will immediately do surgery tomorrow or day after tomorrow. So this 7 to 10 days duration is for planning of the surgery. That's what. It is not that we can trial a conservative method and we can go for operative mode. It's not like that. Okay, I hope you are clear. Any other questions?